Greetings and welcome to AWHONN Insights, the home for candid nursing conversations. We are live from the 2024 AWHONN Convention in Phoenix, Arizona. Today, we're discussing a beginner's guide to liability issues in perinatal nursing with special guest, trial lawyer Adam Snyder, Dr. Lexi Hill, who practices telemedicine full-time to serve communities in need of high-risk obstetrical care, Dr. Suzanne Baird, owner of Clinical Concepts in OB, and Dr. Stephanie Martin, co-owner of Clinical Concepts in OB and co-host of the Critical Care Obstetrics podcast. I'm your host, Bria Anopise, and I'm joined by AWHONN's Director of Fetal Heart Monitoring Programs, Sally Robertson. Sally, I'll now turn the podcast over to you.
Thank you, Bria, and we're very excited to have these great guests with us today for some good legal discussion. So I'm going to start with Adam. So Adam, as a new nurse joining obstetrics, what do I need to know from a legal perspective?
The honest answer, maybe consider orthopedics. No, honestly, the most important thing is if you're already listening to this podcast, you're probably a member of AWHONN, being engaged in the professional organization, staying current with education, relying on your peers, working well with your team, probably the best things you can do, and stick with what you're doing. It's a great area of nursing to be in.
Fantastic. Dr. Martin, I'm going to come to you next. So if I have a national certification as a nurse, such as certified in electronic fetal monitoring or my inpatient obstetric certification, does it increase or decrease my chances of being sued?
I think that's a really good question. You know, having these certifications and extra training or expertise in different areas does not increase or decrease your rates of your likelihood of being sued at all. It doesn't impact it at all, because as a nurse, you are an extension or a representative of the hospital. So if a lawsuit is occurring, you're going to be named in the suit because of your role in caring for the patient, not because of any certifications you may or may not hold. I would say, however, that having these certifications and this extra training and expertise makes you a better nurse. It helps you perform better care. And that's your best defense if you're ever involved in a lawsuit. And if you're in obstetrics, you're likely going to end up being in some sort of a legal situation over the course of a career, because it's quite common. So I strongly recommend and encourage people to get this extra education and certifications, maintain it, maintain lifelong learning. It'll make you a better nurse. And that's your best defense if you're ever in a legal situation. Adam, you have any thoughts on that?
Yeah, one thing if you think about it on the flip side, would you want to be sitting in the deposition chair or in the witness chair testifying in front of a jury and not have gone through the training or the certification that you could have gone through? I think you absolutely would prefer to be in, have that in your background as opposed to no training.
Yeah, and I've read depositions where nurses are saying that they are teaching, for example, fetal monitoring courses, yet when you read the depositions, they're not able to give basic definitions. They're not able to really adhere to the things that they're actually teaching. So it's super important not only that you have these certifications, but that you implement them at the bedside and be prepared if you're ever in a deposition situation so that you can give basic terminology and definitions, whether you're an instructor or not. I'm sure Suzanne has some opinions on that.
Yeah, certainly. That comes up every deposition for every nurse. If you are giving a deposition in care that you've provided, they're going to ask you basic terminology, especially in regards to fetal monitoring. And you need to be prepared to give textbook definitions. Same thing with, let's say, a patient had an abruption. You need to know what that is and how you recognize it and how you would communicate those signs and symptoms to the provider, and how you prepared to, implement certain resuscitation measures, whether that be for the fetus or for the mother. So you need to know that basic information, and that includes that physiology and pathophysiology of all the care that you're providing. And I think certification, when you look at the questions and certifications, they rely on your knowledge of that physiology and pathophysiology, then how you would manage it, which signs and symptoms you may want to communicate to the physician. When would you ask the physician to come to the bedside? And this would include midwives as well, depending upon which clinical practice or which scenario you're talking about. But certainly you've got to notify, but you have to recognize first. So certification just says, you've gone to the extent of studying and learning that information, and you are knowledgeable about it. So I think it really helps nurses to have that certification.
Excellent answers. So Adam, another question I hear a lot from nurses that have practiced for even a short time in their career or a long time in their career is, what's the statute of limitations on these obstetric cases? How long do I need to sweat it?
Well, that's a great question. Unfortunately, you're going to get a very lawyerly type answer, and that it's different in a lot of cases. Federally, nurses who may be employed in a federal clinic or a practice that's funded by the federal government, that would be covered by the Federal Tort Claims Act. And that law typically limits the time period to 2 years. A lot of states have a 2-year deadline. It's different in other states. Some states as short as 1 year. Some states, and depending on the type of injury, if it's a child that's involved with significant neurologic damage or brain damage, in Illinois, the statute could be for the child's life. The typical rule in Illinois is 2 years, 8 in the cases of a minor, but longer when there's something like cerebral palsy. And many states have exceptions, taking the statute or the deadline to file a lawsuit out 3 years, 7 years, 10 years, but it is state by state.
All right.
Sorry about that. Let me just add one thing. Sorry, I didn't mean to interrupt. I recently did a 19-year case, a case from 19 years ago. So I just wanted to add, this is, to me, that's the best rationale for really documenting what you're thinking as you provide care for these patients, because we've gotten so into the drop-down click boxes. And everybody pushes that because they can warehouse the data and then go back and run reports on it. But for your own information, just really documenting what you were thinking as you were doing your care is so important, because 19 years ago, I don't know what I was doing. I'd have to look at my CV probably just to even tell you where I was living and what I was doing at the time. So imagine a case that was really insignificant to you at that time. You might not have written a lot of details about, the care that you were providing, but much less what you were thinking and why you did it. And so it really makes a difference, because that statute of limitations can be a long time.
We all teach together frequently, and this topic comes up a lot. Mm-hmm. And one of the ways that I've heard it said best by a former colleague of mine was that the chart is supposed to tell a story. And if it doesn't tell your story about your thoughtfulness and what your plan of care was, it will be the plaintiff and the plaintiff expert and the other witnesses who tell their story. So your best defense and the best way to provide quality care is to thoroughly document what you were thinking at the time those thoughts are running through your head.
The only thing I was going to add to that is, not only can there be such a delay when a suit is filed, but once that's filed, the time in which it's filed until you get deposed can then be many more years possibly. So, when you're thinking how far out could it go in your mind, if the answer in your state or your thought is, it's 2 to 7 years or something along those lines, that may just be for the time for it to be filed, not for the time in which you or someone could actually be deposed. So, when we're thinking about this and like how long out could it go, it could be a really long time.
I've also found that the cases that you think are going to have a suit against them are not necessarily the cases that have the suit. It's the one you had no idea. And all of a sudden, the documentation that you did, that your normal documentation just doesn't tell that story. So I think that's a really good point, is every patient you have, like Adam said, provide great patient care and document about it. Everything you're thinking and everything you're doing, because that is the best defense for sure.
Yeah, and to kind of just expand on that, probably the most common question that we get in these kind of forums is, can I get sued for this? And the answer is, you can get sued for anything. Anybody can sue you for anything at any time, really. So consistency in the way you document and communicate really, and thoroughness is really your best defense, because like Sally's saying, when you have a catastrophic outcome, people assume that some sort of a suit will be filed, but these outcomes may not become apparent for many years after you've ever interacted with the patient. And so you may have no idea that there was ever an adverse outcome at all related to the care that you or someone else may or may not have provided.
All this talk makes me kind of nervous. Maybe I should do orthopedics, like Adam said. No, I love labor and delivery and taking care of moms, and I know our nurses do too. So, Suzanne, this is a great question for you. Is membership in my professional organization important for liability purposes?
Thanks, Sally, for that softball question. I love that. Yes, it is. Again, reading nursing depositions and having to hear a nurse say, it's our association, but I don't exactly remember what it stands for. Or they say AWHONN stands for something that completely doesn't exist. So being a member and being involved is essential for nurses. I mean, if you could start off every deposition and you could read every single nurse to say, I'm a member of AWHONN, I'm active in our local and section, and I've done this in AWHONN and things like that, your credibility and your just what the attorney automatically may even have to shift gears somewhat, depending upon what the case is about, and it really helps to have that background and that information, because that attorney at that time then knows that you are keeping up to date more likely than not, and that you are interacting with other care providers in your specialty.
You have a nurse one time who testified, confused AWHONN with A1 steak sauce, something along those lines.
Yeah. Yeah, it was something like that. And she, and in that, okay, so you hear that scenario, you hear that, and it's true. And again, I've read a lot of times they're like, it's association of, I don't know, something, I can't remember, and certainly you're nervous during a deposition, and everybody understands that. But if you're involved with AWHONN and you're a member, then you know what it stands for, and you can speak to, what you receive in the mail, what you have access to online, and the information that AWHONN puts out, you have access to that. So it's so important that nurses are a member of AWHONN, and that, again, actively participating will even enhance that even more.
So Adam, I have an off-script question for you. What is more important, being a member of AWHONN as an obstetric nurse, or having insurance?
Well, okay, I'll answer this question as kindly as I can. First, I think being a member and being active, being engaged, being educated, and up to date are the most important things. That's always going to be your best avenue for providing quality care. And by the way, if you are watching this and you see us looking around, we are all sitting in the same room. The insurance, I'm an AWHONN member. I'm not a nurse, but I get the same brochure that you do. I think you should read it carefully. The insurance, in some circumstances, could be beneficial. I think there are other circumstances that are probably more common where it may not provide as much protection as you think, because it is typically excess insurance that you're purchasing for a small amount of money, which means it only kicks in after all other liability insurance has paid, or most other plans have paid. And if you work for a hospital, that could be quite a great deal of coverage. So the most important thing is being a member, but being an active member, not just a member in name only.
Fantastic. Thank you. Sorry for that off script question. All right. So Dr. Lexi, we haven't heard from you yet. So your question is continuing education necessary to improve care for patients?
Yes. Absolutely. And, there are certain states for nurses that do or don't require certain types of continuing education. For physicians, we are required to have it. For sonographers that are in the obstetrical world, they are required to have certain number of credit hours per certain number of years. And I think definitely it's important. And the reason being, it's great to get the most updated articles because those are typically the ones included for these continuing medical education criteria that you have. And the other thing that's kind of neat is that across the US, every state, at least for physicians, is different in what they require for CMEs. So some may really focus on child trafficking at one point, some may focus on opioids, and it's different. So for nurses, I would assume that it really has to be very similar. And Sally, you might can help me with this a little bit too, that it's different. And so if you're a traveling nurse or you're starting a different job in a different state, even maybe in a different city, they could have different requirements. And certain hospitals may encourage you or require you to do other types of certifications or get other types of credits. So yes, it's very important. And the other thing too is just it's really good for your education. So when you're, continuing your training, we're always teachers, we're always learners, we're always teachers. And so I think it really keeps you as up to date as you can with what's going on in the field. And from a legal standpoint too, anytime you get involved in something that's medical legally kind of charged or happening, it keeps you really on the forefront of what's going on in your field.
Yeah, I think that's great. I have practiced nursing in 4 different states, and all 4 states had different requirements for nursing continuing education. The first state I was in had no requirement at the time, which, as a member of AWHONN, I still did continuing education because I came to their amazing national convention that we're here now in Phoenix. Other states, the state I'm currently in right now, has a requirement for all nurses to have sexual trafficking continuing education every time they renew their license because we're number 3 in the nation for sex trafficking. So I think that exactly what you said, Dr. Lexi, it's important not only if your state requires it, but it's important to be that continual learner so that we can get great patient care across the board and have, I think, interesting conversations and intelligible conversations with our providers so that they know that we're keeping up on it as well.
I got to say, and we are big promoters in interprofessional education together. When you learn together, you play well together. So it's a team effort in providing care. And so learning together, you're all on the same, singing from the same sheet of music, as you might say, especially in regards to like fetal monitoring. And one of the first questions you're going to be asked in a deposition was, when was your last educated in fetal monitoring? And not just for the nurses, but for physicians too, or midwives. And you would be shocked to see what, some clinicians say. I think for the most part, most nurses are educated every couple of years at least. In fetal monitoring, maybe even yearly. But I've had some depositions for physicians that haven't been educated in fetal monitoring in quite some time. So I think that learning together for physicians and nurses, especially in that realm, is so helpful.
I'll add one quick little comment. It's really, really helpful, especially if you're a new nurse, a new provider. Keep a file on your computer with all your certificates. So I have a little file that just says CME. And if I do anything for a new hospital, a new system where they required something extra, that's a CME credit that I I earned it, probably paid for it too, to do the CMEs, right? But keep those on there as you're going along, which is, it's just super, super helpful so that if ever 5 years from now, you can pull up your file and say, at the time in which this lawsuit was filed, I was certified. I was up to date at that time. I had ACLS, BLS, whatever, just so that you have all that information there. It's really, really nice to keep in case you change jobs and they're asking if you have those required CMEs or what your current CME status would be.
So I just have to do a little plug for the A1 fetal heart monitoring program. We do offer both nursing contact hours and CME for anybody that takes the course and does that interprofessional education. All right, Dr. Lexi, back to you because you did so good on the last question. From your experience, what type of cases are common around perinatal and NICU?
I think I'll start with this one and then hand it over to kind of anybody that's here today. From my standpoint, and I do more clinical work inside an office now, so I'm not in the hospital on a day-to-day anymore, and I'm completely happy with that. But I have to say that some of the more common things are things that we have nice protocols for, which is the reason we've developed these protocols through different organizations such as AWHONN to really, really help decrease the mortality that's associated with them. And one of those that pops into all of our minds probably is postpartum hemorrhage. So, you know, when I was training, it was different. It was just, you go to the bedside and evaluate. And then once I became a faculty, they're like, oh, we have a postpartum hemorrhage kit. I'm like, fantastic, you know? So I would say from a maternal standpoint, the two things that stick out for me are going to be maternal hemorrhage and then also anything with regard to preeclampsia, whether it be eclamptic seizures or preeclampsia that was not identified and then later led to fill in the blank, all the fun complications we know about. And we really do have great kind of toolkits, if you want to call them that, or protocols for most all hospitals. And if you don't have those are things that you could take back to your hospital or talk to your, staff there about. So those are the two things from the maternal side. And I'll let some of the other people, because they deal with this more now, I would say, for the fetal side on what they see more medical legally there.
Yeah, I would say number one, the most common thing that I'm seeing right now is maternal death. If there's a maternal death, it's going to be explored, at least as a potential case. And what we see commonly is that it's labeled as amniotic fluid embolism. And it doesn't take much time to figure out that the vast majority of these maternal deaths are not amniotic fluid embolism. There's some other much more common explanations, such as hemorrhage or sepsis, or perhaps stroke or something along those lines. But hemorrhage and sepsis are commonly mistaken for amniotic fluid embolism. So maternal death is right up there at the top. I think, Suzanne, you might want to comment on some of the up and coming things that we're seeing, like abruption becoming a little bit more common, not necessarily things what people would automatically assume are they're most likely to get sued for, but I wonder what you think about that.
Yeah, I see a lot of, uterine rupture, abruption, and a lot of times not only does that lead to fetal compromise, but maternal compromise, acute kidney injury, care in the ICU if a mom gets transferred there, or more than that, they're not transferring the patient until the patient's in shock. So they may have like a RRT policy protocol guidelines at a hospital, and the OB nurses don't follow it, and they don't call to get help to the bedside in a timely manner, or getting a physician to the bedside in a timely manner is really big for nurses in hospitals. I would think overall, though, the most common cause would be fetal monitoring, interpretation, and Pitocin administration. And in those realms, just everything that's associated that, could go wrong. I mean, for example, a lot of nurses seem to be afraid of Pitocin. Well, Pitocin's a great drug. I mean, we need to say it. Pitocin is a fabulous drug when used properly. And it's a high alert med. That's one thing they're going to say. And sure, we use a lot of high alert meds in OB, but when you give Pitocin, it does a great job, what we want it to do. So just knowing how to administer it and your guidelines at your hospital and what those are, and make sure that you follow those. And if you have a question, then we discuss it.
Yeah, and I think there's kind of two ways to look at this. So there's the reason that the lawsuit is filed, which is usually related to an outcome of some sort, a maternal death, a hemorrhage with massive transfusion, ICU admission for septic shock, whatever it may be. And then when we get into the case, there's the issues that are identified around the reason for the lawsuit. So communication or lack of communication between providers, failure to recognize maternal deterioration or fetal deterioration because you're not interpreting the fetal heart rate tracing correctly and acting appropriately, inappropriate use of oxytocin, inappropriate or lack of resuscitation of a depressed neonate, not having the appropriate providers at a high risk birth, etc. So there's the reason the suit is brought, and then there's the issues identified within the case that make it more likely to be defensible versus more likely to be indefensible. And that's where the battle begins that Adam probably has some thoughts on.
Those things are probably deal with normalizing the abnormal, not recognizing that vital signs are telling you one story and that the patient is headed in one direction, and just not responding to it fast enough. A lot of the worst cases that we see, it's not just one thing that goes wrong. A lot of things go wrong.
Great answers for sure. So, Suzanne, what role would a nurse have in a legal case when a provider is named?
Are you talking about like if the hospital's named
Yes.
as well, or if the
Hospital
hospital's
and
not
provider are
okay.
named. What role does that nurse have that took care of that patient?
Okay, so the nurse taking care of the patient will be called to describe the care that they provided during that time period that they were taking care of the patient. So they would go through the case and the care that they provided, provide rationales. They'll be asked about why did you do that? What were you thinking? Those types of things. As far as, and the hospital attorney would represent the nurse. So I wanted to make sure that is well understood. So the hospital would represent the nurse, and then that nurse would just review the care. Were you wanting to have an answer also that what else a role would be for a nurse in that, if they, or is it just for the named nurses?
I think it's important not only for the named nurses in the case, but I think their leadership, right? Their directors, their managers, what role could they help the nurse with that's going through something as stressful as this?
Yeah, so in a case too, a charge nurse will usually be called. The charge nurse will be called for deposition to ask that charge nurse if they were aware of what was going on. Did they go into the room? Did they assist in care? What actions was the charge nurse doing at that time? Another person that may be deposed in the case may be the nurse leaders for that area. So like the manager or director level. And I think that those roles to support the nurse during that time is very important. But one of the main questions that you will be asked in a deposition as a nurse, whether in whatever role you are, is have you discussed this case with anybody else? It's one of the first things that they will ask you. So all conversations that you're having about the case should go through risk management and be discussing it with them versus having conversations at the nurse's station or even in the manager's office. So support is one thing, but I think having support by the risk management department is essential. And Adam, you may have an opinion or something you want to say about that.
Well, I heard the question. I just want to address a little bit different issue, and that is, if you have a physician and a nurse both involved in a lawsuit as witnesses, it's never going to be acceptable to say, well, I was just the nurse. I was following the physician's orders. I didn't have an order for that. and just put it onto the physician, or vice versa, for the provider to say, well, the nurses were the one at the bedside, and I was depending on them to make sure they kept me updated. Both of you, each role is individually licensed for a reason, with individual expectations. So we call that the standard of care. And if, as a nurse, you feel that something more needs to be done for the best interest of your patient, then there are things that you have to do to make sure that you advocate for your patient. That includes activating the chain of command, going to the house officer, the chief nursing officer, the director of the unit, the manager, getting them involved. It's not enough. It's never going to work at trial or in the deposition room to say, what was I supposed to do? I didn't have that order. It just won't work.
There was one quick thing I was going to say, since we were mentioning a couple of times depositions and whatnot. There is a great Audible book called Deposition Preparation, and it's Edwin Sinclair. If you ever are being deposed, even if you're not, but if you have that coming up or know someone that does, it is a very, very short little listen, and it is fascinatingly interesting to hear some of the depositions in the past of famous people that they have on file and the things that they said. You're like, I would never say that. But when you're deposed, it becomes public record. Is this correct, Adam? Should you shake your head? Yes. Is that right? Okay. That's what I thought. So what you're saying, it's kind of like when we're doing this, right? We think we're using proper English as best we can, but when we speak quickly, we may speak a little different or not conjugate something appropriate, or we know what we mean to say, but we say it differently. And also the way in which we answer, if we're nervous, could be completely different the day of. We don't know what to expect. So if you're going to do anything on your own preparation, minus the things you should do by meeting with your attorney, talking to the appropriate people, all those things. But this deposition preparation, Edwin Sinclair, is absolutely phenomenal to listen to and gives you something to mentally and overall prepare prior to.
I just want to kind of expand on what you were saying, Adam, with the physician nurse role in a suit, where it's a pretty challenging situation to be in for many reasons. But part of it is that when you're at the bedside taking care of the patient, you're supposed to be on the same team trying to accomplish the same goal for the patient. But when it gets into a lawsuit stage, the attorneys are often going to be trying to pit nurse versus physician because you have individual representation for the most part. And if you start having conflict and blaming going on between the two groups, it makes it easier. It's a divide and conquer, and blame starts happening, and then it becomes easier to just blow apart the whole case, really, and accomplish individual goals instead of trying to defend the case as a team. I had a physician one time in deposition where I read that they actually said, I wasn't worried about the patient because the nurse was calm on the phone, instead of reacting to the shock vital signs, profound hypotension, tachycardia in the setting of ongoing hemorrhage. But because the nurse was calm, the physician was falsely reassured. And people say things in deposition that can really get them into trouble. But the important thing to recognize is that they are going to try and divide you, and you do have separate representation, typically with separate goals. The physician representation is to defend the physician. The nurse representation is to defend the nurse and the hospital. That's just generally speaking. Most of the time it's like that. So it's very counterintuitive and challenging, and it's very easy to get into those traps where you get triangulated and fingers started to be pointed, and it's Adam's a dream situation, right?
I'd take a little offense. I don't think we're trying to divide. I think we're trying to figure out whether or not there was a breakdown in communication. The nurse or the bedside provider is saying one thing, and the person on the other end of the line is hearing something different. And
I think that's true for you.
Yeah.
Suzanne, I want a follow-up question on this with you. So I'm a nurse taking care of a patient. I call the provider. The provider is not understanding my level of concern and is maybe refusing to come to the bedside or give an order. What do I do next?
I call it down home communication, or, you just want to have a conversation. Say, here's my concern. I want you to come to the bedside. I think one of the things that nurses leave out a lot of times is, I want you to come to the bedside, and they're very specific about that. And it's my experience that when I say that, then they come to the bedside. And if they, for some reason, cannot, then I ask the question. Again, they're my teammate. And so I say, the quarterback got hurt. I need to have somebody fill in that role. So if the quarterback is laying on the field and I need somebody to fill in that role, I need to get somebody to fill in that role. And I just say that. So if you can't come to the bedside, who can I call? And I ask that question because it may be that they physically can't get there. They may be in the OR. So what would you do in that situation as well? So you always have this in the back of your mind. I don't think that we ever should take it like nobody wants to do what you're asking for, and don't assume that. You just need to have a conversation. Here's my concern. Here's what I want you to do. And this is why. And if you can't come, then I need to get somebody else to physically come to the bedside and assess this patient. Nurses cannot make medical diagnosis. So our job is to assess, to recognize abnormal assessment parameters, to communicate those. And then if it requires a medical diagnosis or interventions, then you do those, and the medical diagnosis comes from the physician or nurse midwife. So and then we start our assessment all over again. That's called the nursing process. It's what we learned in nursing school. So if that's just a common teammate response.
And I mean, there's a bunch of situations where this becomes problematic, but again, think about it from the jury's perspective. If you take this all the way through, the jury is going to be thinking about their daughter, their partner, their mother, their family member, and how they would want them treated by you. And a great example is a case where a clinician was en route. There was a serious concern. The patient needed to be delivered then, not 30 minutes later when the physician who was en route was going to arrive. There was an on-call OBGYN in the hospital available, actually involved in the phone call to the physician who was en route. But to avoid stepping on toes, the appearance of stepping on toes, they weren't allowed to take the patient to the OR. And the outcome was that the delivery was delayed by 35, 40 more minutes with a pretty poor outcome for the little girl involved. And think about it from the jury's perspective. It's an unacceptable delay. That's not what they would want. They would want, you have a surgeon who's trained, who's capable, you have an empty OR, you have an anesthesiologist ready to go. Move the patient in the direction they need to be moved.
Yeah, and I would say that's, I completely 100% agree with both of those, assuming that the nurse recognizes that someone needs to come into the hospital or come to the bedside to see the patient. And so if you take it back even a step further, standardizing your processes on the unit so that it's defined at minimum standard when somebody needs to come to the bedside to see the patient. I've given one uterotonic medication and she is continuing to bleed. Someone needs to come to the bedside, period. I've given a single dose of labetalol. Her hypertension persists. Someone is coming to the bedside. This is no longer nursing judgment. It's an established protocol on the unit. And for nurses who are maybe more new or who have less experience in OB or who have had bad experiences with providers in general or particular providers being nasty or inappropriate to them, this is where your colleagues and your charge nurses need to be utilized to back you up. If you're not certain and you don't have it clearly defined that this person needs to come to the bedside, get your colleagues to review the situation with you and say, what do you think? What do you think? And then help you. And nurses who have more experience, this is your opportunity to mentor that nurse into this is how the communication will be done. You do the communication, but I will physically stand next to you and I've got you, because it can be incredibly intimidating to talk to some of these providers that, you know, are not willing to come in, not willing to come to the bedside, or are just rude or inappropriate. And I'm a physician, I'll say it. I know some of us aren't always that nice. And we need to do better. But I think the opportunities on both sides for the more experienced nurse and the less experienced nurse to help each other to do the right thing for the patient and not be intimidated to speak up.
I love how Dr. Martin brings up being objective, because objective data is not your opinion. It's not how you feel. It's objective. And I know that she has a love for vital signs are vital, right? So if anybody's having trouble getting some information across, think objectively. Think about the volume of blood loss is this, the heart rate is this. Give a very descriptive information as opposed to using kind of like opinions or soft words. And that brings me into, I have two recommendations on, I feel like someone could be listening and saying, no, I feel like I say these things to the provider or provider to nurse, whomever, and it's taking care of the patient, and they're not hearing me. I have two things that are helpful. Number one, shout out to Brene Brown. One day I will meet her. Clear is kind, unclear is unkind. And this is one of the most favorite things I've read and that has resonated with me from her books, is because be as clear as you can. And part of that clarity is what Dr. Martin says about objectivity. Be clear in your words and your communication as best you can, as opposed to get here now, right? Like, hey, this person has these objective things. So being clear, that's number one. Second thing is asking the question, if you're getting pushback, I love the term, can you help me understand? So if someone is pushing back and saying, I'm not going to come, you can, again, it opens up the dialogue of education instead of, why won't you come here? Why won't you get over here? That's aggressive, and you're not going to learn much from that. But can you help me understand why the patient does not need to be evaluated? Can you help me understand why you don't feel the patient needs to be evaluated? Can you help me understand why a heart rate of 140 and a blood pressure of 80 over palpable is not warranting your attention, right? You can be a little snarky if you need to, but can you help me understand? It opens the conversation and really helps to show that you are working on being a team player, as opposed to that aggressive, like, why won't you fill in the blank? So those are my two kind of comments. Again, hi, Brene Brown, if you're ever watching.
Absolutely. They're totally in follow-up to this, that they get asked of us often. So one of those questions is, well, how do you document that difficult conversation, especially if the provider's not responding to you or listening to what you're saying? Well, one, leave hyperbole and all of that out of it. Be factual, be objective. Put down what your thinking was and the data. Second, I often hear, and I've heard from nurses directly, I've called so-and-so 3 times, they're not coming in, they're not responding, they're not reacting. Well, eventually your plan, you have to recognize, is not working, and you need a different plan. If you feel strongly for the patient, they need care now, you need to change up your plan. It will not be acceptable to me or anyone else in the deposition room, even to your own experts probably, if you say, well, I just kept on calling and they kept not coming, what more was I supposed to do? That's, again, where the chain of command can be helpful. Relying on your colleagues can be helpful.
Can I just add to that too, one last thing? Really, depending on your hospital where you work, your chain of command can be really long or it can be very short. Some hospitals may be the only physician in the county. Especially as we get into maternal care deserts, even more so. So chain of command is a thing in some hospitals, and in other hospitals there's no such thing. But we can get a chain of command going, and just even with notification of our charge nurse again, or your director, your manager, or something like that, letting them know what's going on. If that gets drug out, also chain of command, really you have to have time to do that. If it's an emergent event, you don't have time to say, okay, time out, I've got to go and go up my chain of command. But if I ever do go up my chain of command, I do let the provider know that I'm still concerned, and I may not be, you may not be getting what you're wanting, and you're still concerned because the patient's still compromised or the fetus is compromised. Then I just say, well, if you can't come in and see this patient, then I'm going to need to notify somebody else, and I'm going to notify that in the back of my mind, and I know what to do. And I think that that's also in the kindness part of it, or in the professional aspect of it, then that's professional. And again, I notify my teammate that I'm gonna do something different.
Yeah, and on our podcast, the Critical Care Obstetrics podcast, Julie Arafay is one of our partners, and she has a whole episode on the chain of command, because that is a really tricky one, and you can destroy a relationship if you use it as a weapon instead of as a way to actually build the team and get something done for your patient. But this escalation issue brings to mind a couple of years ago, I think we all heard about the situation in a hospital, and I can't remember what state. Someone listening will probably know. But in the emergency department, they were overwhelmed and understaffed, and they felt that the only way that they could achieve what was necessary for the patients in the emergency department was to call 911. And they called 911, and the fire department arrived, and paramedics in the fire department started triaging patients in that emergency department, because those are nurses and physicians presumably advocating for their patients, because they recognized they had a real situation that they had to solve, and they didn't just take no for an answer. They figured it out and got through it. Obviously, there's bigger issues there, but that's the ultimate escalation, right?
I'll just say I threatened to do that one time in an emergency room for my kid. He got seen.
This is such great discussion, and I think really good, especially for our new nurses. I also want to not skim over the debrief. So after there is a situation, it's really important to get that team together and debrief so that we can learn from it and make sure that hopefully it doesn't happen again. And so we can be better for our patients over and over again. Okay, let's see where we are. I think we talked a lot about the communication between providers. So I'm going to go actually to Dr. Lexi. So I'm going to change your role from a physician to a nurse. So you are a nurse in an emergency situation, and the provider that's at your bedside is a resident, and maybe you haven't worked with a resident before. What advice would you have for that nurse in that emergent situation on how to work with that resident?
I love this question because I love to tell this story, and this just opens up to this. So teach them. That's the best thing I can say. And I say that from being the resident where a nurse helped me. And I'll give you this scenario. I was an intern, patient was delivering. The head comes out, shoulders aren't coming. The head is blue. There's a tight double nuchal. And I look at the nurse and I'm like, I don't know what to do. I mean, I didn't know what to do. And she turned this patient over in Gaskins and got her all, and that baby delivered. And I looked at her and I was like, thank you so much. And she's like, I got you. I'm like, I got you. Like, what do you need? What can I do for you? But I believe at that time she had been experienced, but even had she been, I don't care, new, old, young, whatever, she was my saving grace. And so many nurses, thankfully, that I worked with were that saving grace. So what I would say as a nurse with a resident is teach them and be open to teaching them, because we as physicians, I can't take a Foley catheter out. I tried to help a nurse one time and take a Foley out, pee went everywhere. She's like, gravity, you have to hold it above the bag, above the thing. I'm like, how would I know that? No one taught me that. I can't do those things. So, if you ever run into a resident that's not taking your help, your knowledge, the wonderful things you have to offer, that may be a situation where you may want to pull them aside, and I would be fine. Some of my fellow residents got pulled aside by nurses because when the nurse called and said, hey, we have a patient for you, they were like, I'm taking a nap. And I was like, I would not do that. Like, the last person you want to tick off are the nurses that are busting their butts with your patients 24/7 when they're on those shifts, and being a team player. Like, that didn't jive with me. So I would say teach us, because we don't know what we don't know. And I love to teach other people too, but man, I love to learn. And I am super jazzed when someone is like, oh, did you know this? And I'm like, I did not know that. Especially in an emergency situation, I guarantee you, I never would have, in my mind, I'm thinking what the books taught me, right? I'm not thinking flip this lady over on hands and knees, never crossed my mind. But those kinds of things are fantastic. And that nurse and I worked together like 15 years later, and we helped each other out in a teamwork situation that goes above and beyond. And she's like, I'm getting chills to this day, one of my favorite people, and like taught me so much. And so teach them.
I think to expand on that, the point Lexi is making is huge, because residents are learners. Okay. And so if you are working in a situation with learners, you need to understand that they're learners. So you have a role in teaching them, but their attendings also have a role in teaching them. You need to clearly understand what their scope of responsibility is and make sure that you have the right level of provider at the bedside for the type of situation that you're in. So if you've got a patient in, cardiac arrest, you need more than a resident there. You need to be escalating. If you've got a patient in, a different kind of situation, you may just need a chief resident there. So you need to understand what everybody's role is and what their limitations are, and how and when to escalate up that chain of responsibility based on the learner's capabilities, experience, and scope of practice.
I love working with residents, and so I love the community of residents and nurses and attendings and midwives, and just learning from each other. And they have a different background than we do, and we just working together. I love the scenarios that y'all gave, and I'll give another one. I remember coming on night shift one day, and it was 11 p.m. I was in charge, and I come to the desk and I go, "Who's in room 5?" That is not ever good when somebody asks that question at the nurses station. And and everybody immediately looks at the central monitor, and it has something to do with the fetus. And everybody sitting around said, "Oh, that's Miss So-and-so. She, her fetus does that." And I was like, "Does what?" And they were like, has tachycardia, minimal to absent variability and recurrent lates, and just does that. We've been watching it, and I'm like, "Are y'all hearing what you're saying?" So I called the intern first, line of request, and the intern comes out, and it probably was August or something, July. And the intern says, "Oh, I've seen worse tracings." And I'm like, "Okay, next." So I go straight to the chief. So, know your chain, and again, in some hospitals, you might not have one, but others, like a teaching hospital working with residents, that chain can get pretty long. So I like the idea of being learners. We're all learners all the time, but residents are learners.
Sounds like that baby wasn't happy.
Yeah, that's a favorite of Adam's. Is that baby happy?
Well, this has just been amazing. You guys have such great feedback and answers to the questions. I know that our nurses, whether they are brand new to obstetrics or thinking about changing to orthopedics now, or have been nurses for a long time, have appreciated your insight. So I'm going to turn it over to Bria and let her finish up for us.
Oh, wow. This was a really rich conversation. We want to thank our guests, Adam and Drs. Lexi, Dr. Baird, and Martin, for your expertise, examples, and insights on these important legal matters related to nursing clinical practice. And thank you, Sally, for co-hosting with me today. I so appreciate your time. And to all of our listeners, thank you for tuning in live with us today, giving us the privilege of your time. Please share how much you enjoyed this episode by leaving us a review and telling a colleague or friend. You can visit awhon.org/podcast to read our guests' full bios and download the resources they shared with us today. You can also rewatch us on YouTube. Thank you again. Be well and stay safe.